So we're actually getting ready to put together a program about sensory changes with dementia and how we can best help our individuals make sense of their world and be comfortable in the world that they're in. So with no further ado, we're talking about demystifying dementia behaviors. And I don't like the term behaviors because when we think about that, the word behavior itself has a negative connotation. It means something negative for most people. But go with me for a second. We're going to take a trip on a plane to a foreign land. On this plane, you don't have to wear a mask. That's how you know that this is not real. But you are on this long journey and you finally land. And one of the things you haven't been able to do is use the restroom. So now you get off the plane and you're trying to convey to somebody that you really have to use the restroom. And they're not able to understand you. They're not speaking your same language. So pretty soon you're meeting critical mass and you need to do something about this. So how do you really show somebody that you have got to use the restroom? Pretty soon you're playing charades in the parking lot so that somebody will understand. And that's kind of what happens with dementia. We call it a behavior because people are getting a little bit more frustrated. They're not able to verbalize all their needs, but actually what this is an expression of their need. And so we're going to talk about what dementia is, what it isn't. And of course, we're going to be looking at several things that we call behaviors. And again, I want to say that that's really an expression of their need. And we also have to understand that one of the things that makes this such a big deal is that our reactions can actually complicate things quite a little bit. And this especially when you have younger caregivers who really don't understand this disease process and what it's doing to that brain, they become a little short with these individuals. And what we need to do is do teaching, hand-holding, and heart-holding and help to educate them so that they understand what is happening. So our goals of care are to promote that comfort. And to some degree, they've actually become time travelers. We have a responsibility. I am so sorry. We have a responsibility. So when we are taking care of somebody, we need to know who they are. And you're only going to do that if you take the time to talk to the family and observe that person, to find out who they are, how they tick, really. It's very important so that we can travel with them, so that when they ask questions, we can give an answer that makes sense. And so that we can also support that family through that education to help them not just deal with what they see as a behavior, but we can also help them to have a meaningful visit. One of the things that I see is people don't visit as often. Or I hear people say, well, you know, we have the same conversation. I don't know what to say to mom or dad. They're just not there anymore. Well, they're there. We just have to find a way to reach out and touch them and meet them where they are. Have you ever walked into a room and forgotten what you were there for? Unless it's the bathroom, you generally, if you're walking in the basement, did I come down here to get some soup or what did I come down here for? We just don't know.
You never get this to link with the iPad.
So does that mean that we have dementia? No, because dementia is actually two Greek words put together, D without, mentia, memory.
Where's the other thing?
And there are approximately 120 types of dementia, which simply means loss of memory or memory impairment to some degree. It can be as simple as brain fog. You haven't slept very well, you're not thinking very well, or it could be stress, because stress is definitely going to do that. Or it could be a disease process. Lyme disease is one of the causes of this. So when
Andy, can you unmute yourself? Thanks.
So when we have a loss of memory. It doesn't mean that we have dementia. It's just that maybe we're hard drive is getting full and we have a reason where maybe our mind isn't tracking on something. But when we have dementia, when we talk about people with dementia, we think that that's the disease. It's not. It's a symptom of the disease or a condition, but it is not anything more than really a symptom. And sometimes we can treat those symptoms and actually reverse things. It's really incredible. So if you have a cold and you have a runny nose, you oftentimes will say, I have a cold. The symptom of that cold is the runny nose. You don't say, I have runny nose. No, we say we have a cold. So when we have somebody that is experiencing or displaying a lack of memory at that moment, we need to explore any cause that we can to see if there's something that's reversible, because there are quite a few things that are reversible. Now, when we look at true disease processes, these are things that are not reversible. We can slow them down to some degree, but we aren't going to be able to reverse these situations. So Alzheimer's is the most common, probably about 80%. Frontotemporal, this can hit people as young as 30 years of age. And this is really sad because these are individuals that it's hitting that frontal lobe where we have thinking and reasoning and judgment. And they sometimes will say things that are completely off the wall, maybe even challenging or rude. And you just never know when it's going to happen. And going down this list, you can see that there are quite a few things that will cause true non-reversible memory loss. Each one of these disease processes I find very interesting because your person with Alzheimer's, they're going to follow generally a trajectory. Your frontotemporal, it's going to have a trajectory, but it's all over the place. Creutzfeldt-Jacobs disease has a trajectory, but vascular dementia, it's a little bit more over the map, and Lewy body is definitely a challenge. So those are some of the true disease processes, and you're not going to reverse that memory loss once it's present. But the reversible causes can be something as simple as a medication. We actually just had a neighbor the night before last who called a friend and she said, I've just been ghosted. And she says, ghosted? In which, we know what ghosted means. They've cut you off somehow. But in her case, she was seeing ghosts and they were walking through the house and she wasn't really afraid of them until they started levitating the bed. What had happened, she had started a medication and it caused her to have some hallucinations and some very strange reactions to it. So medications can be one of those things. Infection, particularly UTI, this is one of the huge ones. If I see my patient on Monday and they're fine, they're their normal little selves, but I see them again on Thursday and they're pretty off the wall, the first thing I'm going to do is wonder what's going on with their urine, and I'm going to test it. Dehydration and malnutrition, those are again reversible. If we don't drink enough water, we're not getting enough fluids, we're not getting enough electrolytes in our bodies. And stress. If you had Jennifer Jensen, I'm going to ask you to unmute for a second. Can you do that? What did you have for dinner last night?
I had a butternut squash enchilada.
Okay. Did it pop into your head instantly or did you have to stop and think?
I mean, I had to stop and think, but it was like, I don't know, 3 seconds, whatever.
Yeah, it wasn't long. You can mute, thank you. But the whole point to that was if you catch somebody off guard and you ask them a question that they should know, like, where do you work, or what's your address, or what did you have for dinner or breakfast, sometimes you do have to stop and think. So stress is definitely one of those things. And we're seeing a little bit more stress-related memory impairment, primarily because of the COVID and the impact that it's having. But there are so many various things that can cause this. So Some things are reversible, some things are not. This is just a diagram of what is impacting your brain. And one of the things medications can do is reduce the amount of dopamine in that brain. And we want to have certain things. We want dopamine, serotonin, we want the gabapentin, we want all of these things. And there are so many things that can impact those neurotransmitters in our brain. So again, that's something else that we can look at. I do want to cover delirium. This is something that's a real quick change. This is something that maybe you're going to see in a 12-hour period that is going to impact your person in such a detrimental way. When you have something like this is not something to play with. You have got to find out what is going on with this individual. Now, when I mentioned the urinary tract infection, some people can have an infection that kind of goes along for a few days, and then all of a sudden you start seeing this. And the reason that this is so important is they can become septic. This is another reason why we have to educate our young caregivers to help them to understand that they're with this person so frequently that they have to be able to recognize when something is out of the ordinary for them, so that we can actually help them get this taken care of. It is definitely a big deal. Down on the lower part of the slide, it says injury from a fall. That's chronic traumatic encephalopathy on just a very quick scale. And you think about that, an older person does not have to hit their head and have this giant goose egg to have a brain injury. We think about babies and that shaken baby syndrome and what it does to that brain. Well, that brain is moving around inside the head very rapidly. And so when we have an older person that falls, that brain has atrophied a little bit. And what hasn't changed is the interior of the skull. So they can have that jarring and all of a sudden, or maybe do that multiple times, and they can wind up with a head injury from a fall or a brain injury from a fall and not actually have any evidence of it on the outside. But you're going to see some of those things, the delirium that can come from that. One of the hallmarks of delirium might actually be a fluctuation of their attention or their abilities. So be very mindful that is a medical emergency. I love this slide. Now, I don't know if you can see my cursor, but if you could, you would see that this normal brain, that there are dark areas, and these dark blue areas, these are the ventricles in the brain. These are the holes in your head your mother accused you of having, and yes, you need them, because this is where we're having that fluids and nutrition and what have you go through that brain. It helps to cleanse it, nourish it. But you have areas up here that are on either side of the brain that look like a little bent finger. This is your hippocampus. This is where we have our memories stored. And just below that, on both sides of the brain, in the center, are two little thumbprint areas, and that is your amygdala. This is where you have your emotions. And these work together quite well. But if you closed your eyes right now, and you thought of a particular holiday or a food that you have of a particular holiday, you can actually not only remember the smell of the food and even maybe the taste of the food, it can actually cause you to salivate, but you remember the emotions that come along with that. So there's very intricately tied, not just with memory and feelings, but also the sense of smell. The sense of smell can initiate a memory, which is going to initiate a feeling as well. The bottom part here, where it's nice and red and big blob, this is your cerebellum, and it hooks into the brainstem. And to be very clear, we do not die of Alzheimer's disease. We die of complications. And this is where you're going to have that greatest complication, because this brain will deteriorate. And as you see in the early dementia or Alzheimer's disease slide, the hippocampus is definitely being impacted. And this is where we wind up with some challenging things. We tell somebody, no, you can't drive anymore. Well, you're just wrong because they've been driving for 50 years and you're telling them they can't. It's like arguing with a teenager. And yet you see also that the amygdala is very active. So this is where in the early stages of this disease, we're going to wind up having a few more confrontations. It's normal, it happens. But you also see that these wonderful areas here are now getting bigger. These ventricles are joining up. And it's not that the ventricle is getting bigger, it's that the brain is deteriorating. And so this brain is gradually getting smaller. This 3.5 to 4 pound meatloaf in your head actually can get down to about 1.5 pounds by the end of this disease. The other area that you see down here that's being impacted is that cerebellum. So this person's going to have a lot more problems with falling issues, coordination, maybe not able to dress themselves or feed themselves like they used to. They're going to make a few more messes. And up here in that frontal lobe, you see that the reasoning and the judgment is definitely impaired. So we're going to have problems with them putting on clothes that are right for the weather and that sort of thing. So we really, in this center portion of this disease, which can last anywhere from 4 to 10 to 16 years, we're living longer, not better generally, but this is a long, long period of time. Then we see the advanced disease. And I was talking with Donna earlier about the fact that there are some people who say that they're going back to their childhood. Well, nothing could be sillier. They're not going back to their childhood, but they're losing functional ability, just like a child doesn't have the functional ability. But if you look at this brain, you see again, the hippocampus is really, really destroyed now. We still have a very active emotional system, but down here, you see that that cerebellum is split. So when we look at this person who has the advanced disease, this person probably can't say a whole lot, can't maybe feed themselves or even sit up by themselves or walk. But not only are all of those things impacted, but swallowing is also impacted. And so generally, one of the things that we see quite a little bit is aspiration pneumonias toward the end of life. And when we think about them becoming more childlike, I do want to show you this one. This is the late Alzheimer's brain, and you can see it's relatively primitive, but you can see here where the cerebellum is split. But here's a normal infant brain. And when you understand that one brain is dying and the other brain is maturing, it helps give us a better handle. But I do have to say, it is not that this person with Alzheimer's disease is becoming more childlike. They still are who they are. They just lack ability. And when we talk about activities of daily living, the ADLs, I like to think of it as another dignity lost. And maybe think of that person with a lot more compassion because they can't do for themselves. And the baby, when we got to a certain age, we thought, wow, you know, I'm going to be a singer, a dancer, I'm going to be a movie star, or whatever I'm going to be. But I have never had one person say to me, I hope that when I'm 75, I'm wetting my pants and don't know who my people are. That is just not something we say. So we need to have compassion for these individuals, never mocking them, because this isn't something that they ask for. One of the other things that happens in this brain is that we have to be very mindful of not only what our tone of voice is, but our facial expressions and our body language, because they still have the ability to remember what that means. You're smiling at them, that they equate that with being friendly. But if you've got a scowl on your face because you've had to go in there and clean this person up for the 14th time, and you're pretty aggravated about it, this is the face that sometimes is going to spark some disagreement and some uncooperative behaviors that we see. So be very mindful, not only of your body language, but your tone of voice, what you're saying, and be very mindful that this can get you into a lot of trouble. The other thing that I hope that we would remember and teach and train our younger caregivers is that we need to allow this person to do whatever they can do, because if we are rushing them, we're going to frustrate them. And when we are task oriented, that's what we have a tendency to do, unfortunately. And it can cause more issues for this individual. And so one of the first things that they think of is, well, you know what, we're going to stop that. We're going to go get some Ativan because he's pretty agitated. Are you part of the reason that they were agitated? Think about it. Slow down. Everything we do for them takes from them. Now, other things that might contribute to it are pain. And this is something that's often overlooked because they're not complaining about it. And sometimes they really don't complain about it when there's a reason to complain. But there are things that are going to add to their frustration because, well, one guy in particular comes to my mind. He was really being very fussy. He was striking out at people. He didn't want anybody to touch him. And the facility called and I said, well, when's the last time he was repositioned? Because he can't reposition himself. And they said, well, he won't let us near him. And I said, you got to get near him because you got to get him off of his backside. You know, he's going to have some pressure sores. And so they went ahead and moved him. And what they found was that there was a hypodermic needle in his bed sticking him in the hiney. Once they removed that, they were able to work with him. The other things that we see are oftentimes loneliness, depression, despair. That will increase reports of pain. We're seeing a little bit more of that because of the social isolation and the family's inabilities to get over there. And it is definitely impacting our people with dementias. So be very cautious and remember that COVID isolation for those with dementias is not going to be real pretty. And that might be a source of what you're seeing that's contributing to the behaviors because they can't tell you what it is. Now, we need to focus on the positive. And if what's happening in your world right now is going on in their world, I didn't say that very well, but if you can handle all of this activity, can they? Is it the right time? Is what you're planning to do for them the right activity? So we have to know this person. But let's start out with agitation. We're going to go through some of these things that we typically call behaviors. And let's talk about agitation because that one definitely comes first. If you've had somebody in your car that's driving you nuts, they're trying to tell you that you have to do things. They're basically doing that backseat driving thing. I know when my husband did that to me, I pulled over and I gave him the wheel. So, but I do have a backseat driving license now. My kids got it for me. But it can be very, very disconcerting. And, you know, we might tell somebody, you know, please, I just need to focus on where I'm going. Don't critique everything I'm doing. Just let me drive, please. And they don't stop. Well, we just get a little bit more anxious, a little bit more short. If you've had to tell your kids to settle down in the back seat of the car, and they did, but then they forgot and they just got a little bit rangy again, you're not probably going to be as patient the second time you ask them to please settle down. But when we have somebody that has agitation, we have to first look at the person, the physical. What's happening with them? Have they need of a drink of water or toileting? Are they having some discomfort? And then, of course, whatever we can do to get this at that point and reverse it, maybe we don't go on to the next stage. But we have to listen to them. And by listening to them, we're actually going to look at them. You're going to listen to their tone of voice, but you're going to look at their body language. You're going to look at their facial expression, and you're especially going to look at the eyes. They say that the eyes are the windows to the soul. I believe that they are. And one of the things that we have to also monitor is the environment. What's going on with the environment? There was a caregiver vacuuming a common area, and one of the gentlemen who lived in the dementia wing definitely wanted to leave that area and go into his room. And she would not let him go to his room. The sound of the vacuum cleaner and then her yelling at him over top of it when he was trying to get up and get out of the room actually led to an altercation. It didn't have to be that way. So we have to look at the environment and what's going on too. Because if we don't take care of agitation, when it's agitation, pretty soon we're going to have aggressiveness. That's when they're going to want to punch us in the face, and that's perfectly understandable. Remember that they don't have sometimes the ability to stop and think and put this into word format so that we can understand how we are impacting them. But we do have to look at how are we contributing to this, because honestly, it's very, very common. And sometimes we don't even realize that we're doing it, but we do. So when we have somebody who has gotten a little bit more aggressive, what can we do? First thing you need to do is remember you are in control, and you have to act as calm as you possibly can and make sure that we, again, know this person. And how can we not only calm them down, but redirect this individual into something that's going to be better for them? If we know that there's a trigger that does this, then we have to try to remove that trigger. And sometimes you might actually be that trigger. This person with apathy, this is the person that's really easy to ignore because they don't make a lot of waves. They just sit in their chair and they're nice and quiet. We think that they don't need anything, but they might be expressing some depression because they're either overwhelmed and they don't know how to work within this busy environment, or they're being ignored. And now they are going into this little bit of depression. They might seem a little bit more indifferent. And if this is your facility's social system, is it hindering their ability to move freely and do things for themselves? Now, apathy can act as a barrier to communication and subsequently to care overall. But true apathy, this is something that we can try to work with, but true apathy, when we do everything that we possibly can, we think that we have to give them antidepressants. There is an apathy that hits the brain, and it's where antidepressants can't work. And then we kind of fuss at ourselves because we think we're not doing the right thing. But got to keep trying. Now, their confusion definitely adds to our frustration, but we actually can cause more confusion and their own frustration, again, leading to anxiety and aggressiveness. So what do? We go slow. That's what we should do. And stay calm, because whatever we give to them, they are going to give back to us times 10. And it takes a lot longer for them to calm down after they've been to that level. And when we talk about providing clear, simple, positive instruction, we have to think about what's going on in that brain. It is dying, and it's having a harder time processing what we're trying to tell them. So, slow, simple sentences. Put your socks on your feet. That's 6 words, but 4 to 5 words. Do you know how much you can say actually in only 3 words? Time for lunch, time for bed, time for bingo, whatever. But slow it down a little bit. If they need to have some kind of a reminder, go ahead, demonstrate for them. Put them with somebody who can actually do what you're wanting them to do, like feed themselves. And, sometimes that will stimulate them. But as this disease worsens, we have to use fewer words and we have to do more demonstrating. And remember, they have a disease they didn't ask for. So be kind. Hallucinations, this is very interesting because I showed you the pictures of the brain and you saw how it was breaking down. But in the back of the brain, the occipital lobe, this is where we have our visual center. And we actually have visual center in several different places in our brain. But because that brain is changing, the sensory abilities are changing. The visual distortions are going to be there, more common than hallucinations, unless they have a urinary tract infection or some other thing that's causing a hallucination. Most often with Alzheimer's disease, it's distortions in what they see or what they hear. And so that visual, we see that their acuity has really, really reduced. The depth perception, 35 to 38 inches, and beyond that, maybe looks like dark holes or something that they're going to step into that they don't want to step into. One of my patients actually had the old white and black square tiles in the kitchen, would only step on the white tiles because he didn't want to go in holes. That was sad. But we had another gentleman who wouldn't go into a room that had blue carpet because it looked like water to him. So we have to understand what's going on in their world and help them through that. Another thing that we might think is a hallucination is visually, there might be a coat hanging up and they go over and talk to the coat because they think somebody is there standing there talking to them. Auditorily, if the TV's going and we're talking on our phone, or there's a little group of people over here doing something, they will have a bigger problem with auditory hallucinations. So it's not uncommon for somebody to actually talk to the TV set. It's okay. But when we have a true hallucination, this is what we're going to see with Lewy body dementia very frequently. And they're going to actually see usually small children and animals. And for whatever reason, it's very frequently cats. And everybody knows cats are evil, except for the cat people. They love cats. But maybe that's why they see cats. I don't know. But if it is a good hallucination, go with it. It's something that is fine for them. If it's a bad hallucination, we need to do whatever we can to redirect. But you're never going to tell the person, it's not there, because then you're a liar, pants on fire, and they see it and then they learn not to trust you. I do want to go down to smell and taste and touch. I mean, this is also something that they've done studies where they gave somebody an onion to eat and they told them it was an apple and it tasted like an apple to them. So things are changing in that brain. But if your person feels like something is touching them or crawling on them, make sure that you pay really close attention to this, because it could be a reaction to a medication or food that they've eaten, or even soap that they've had their clothing laundered in. So pay attention to that one. And as I said, if it's a good hallucination, go with it. Not going to hurt anything. Now, this is where, especially with our younger caregivers, that we see a little bit more frustration that builds up in them and then goes obviously to the individual. So we have to remember that their short-term memory is shot. It is gone. And so this is the reason why they're going to repeat those questions. We need to be kind and answer those questions like it's the very first time we've heard it. Maybe you want to change the wording a little bit here and there, but please, before you answer their question for the 10th time or the 20th time, take a deep cleansing breath. And remember, this is something they didn't ask for. The repetition might also be a sign that they are having a little bit more anxiety or agitation. One of the things can do that would be an overstimulating environment. I was doing a program at a very busy building, and people were coming in and the doorbell was ringing and they had a big dog walking around, and this poor lady got so agitated, and you could just, it was heartbreaking to watch what she was going through. And when we got her calmed down and everything, and she was able to be with me, and I gave her a PowerPoint, she was able to be there with me to do the presentation. It kind of backfired because I didn't know she had been an educator, and so she wanted to do the program. So that didn't go over very well. But again, if you have somebody that's doing repetitive either motions or questions, try to find out what might be stimulating this. And especially if they're doing anything repetitive like hand wringing or whatever, give them something to do, but also pay attention to that skin. Because if we wind up with skin breakdown because of the chafing and that kind of thing, we can actually wind up with a skin infection. So pay attention to that. Now, this is where you really do need to know your client, and you need to breathe. If we look at the patterns and the routines, it might help us figure out where we have an unmet need that might actually decrease what we see as sundowning. There are some places in the world, as there's more in the European country, but that they don't use any antipsychotics or anti-anxiety medication because they have built their program around the individual. So for example, George goes into the facility. He used to sleep until 10 o'clock. He'd have his breakfast around 11. But in our facilities, everybody comes in and we have to make them fit our schedule. So that can actually be one of those things. It's a lot more confusing and overstimulating for them. And then, maybe they're really wondering, where am I? It can increase and escalate a lot of the problems. So look at our individual very carefully, look at that routine and see how we might be able to change that routine a little bit, just so that we can avoid some of the sundowning behaviors. It takes about 6 to 8 weeks to actually alter that pattern or routine to the point where we are paying attention to their needs and some of their wants, and can actually get sundowning out of the picture. But it's hard. And we see that more in the, oh dear, the brain is not working. What happened? Anyway, oh dear. That's going to make me nuts. It'll come to me. It'll come to me. But anyway, so Montessori, there we go. See, the little man in my head went looking for it and found it. Thank goodness. I was beginning to question myself. Now, suspicion. This is where we have a real problem. Remember, that brain has been ravaged by this disease, and it forgets where we are now, and it's going back in time a little bit and remembering that past. I actually observed a person one day. She was looking for her husband, and she checking out her watch, and she said, where is my husband? He's usually here by now. And the well-intended caregiver put her hands on the shoulders and she said, your husband died 3 months ago. Did you forget? That was so traumatic for that woman. It was horrible. And I actually had the opportunity to be in the facility when this happened a second time, and the same aide went up there, and I said, no, it's good to be truthful, but not when it's something that's going to cause them harm, and it causes that emotional harm. So we have to learn to give an answer that makes sense, whether it is stealing, infidelity, or looking for something that they've lost. So in this case, when she was asking about where her husband is, I said, I haven't seen your husband yet today, but if I see him, I'm going to tell him you're looking for him. Hey, can you come help me with this over here? And, so acknowledging, redirecting, and it was a much better outcome for this person. But suspicion is something that is definitely going to be there because they have lost things. I do have to say, though, stealing, just because somebody has dementia, if they say that something has been stolen, and this is kind of a new thing, check it out. Because we do have, unfortunately, people who will take things from this individual. And sometimes they recognize. It's not like they just lose it forever. Sometimes they actually do know. So that is something that we need to be very mindful of. And don't try to defend yourself. No, I didn't. Yes, you did, because then the fight is on. And remember, with infidelity, we don't know their past. It might be that a caregiver looks like somebody that their mate had a relationship with. You're not going to be able to defend that either. The only thing you're going to be able to do is to get a different caregiver for that person. And if anybody does have a doppelganger, you want to hope that they're a good one. So also remembering too that the person in the mirror doesn't look the same. It could be that they're accusing themselves. That old woman who came into my room, I think she took it. Well, let's go find some way of finding that woman. And we'll go looking around. But remember, they're not always wrong. Always investigate. It's very important to do that. We had a gentleman that I'm aware of that he had drugs and alcohol and suffered a stroke, and he wound up being a complete care. And he oftentimes didn't make any sense at all. And he started saying, they come in at night and hurt me. Long story short, they had to take him to the hospital. He had a very bad rash on his bottom and between his legs. And they found out that he had an STD and that he had indeed been sexually assaulted in the facility on a fairly regular basis by 2 individuals. So just because it's a claim and they have dementia, just don't ignore it, please. Now, they have lost a lot, but they haven't lost problem-solving skills. I live behind where there was a nursing facility, and there's woods and field and everything. And we had a gentleman who was actually found head first in the drainage ditch. He had gotten out of the building, even though he had a wander guard on. And the staff got so used to him going to the door and then away from the door, he would go away when the alarm rang. But he knew if he got on the other side of that door, the alarm would stop as well. And he was actually found head first in that drainage ditch, like I said. And that was the 3rd time he'd gotten out. So we have to remember that if the alarms are ringing, pay attention to them. Don't just assume. Always look. Always look. Because 6 out of every 10 people with Alzheimer's disease are very likely to wander. And it's dangerous because when they're lost, they're unable sometimes to retrace their steps. Oftentimes they don't turn around. And that can be really dangerous because if they're walking in a body of water, they just continue to go forward. And we oftentimes will find people that have wandered away from care facilities drowned. And that's a very sad situation, obviously. But if they're wandering, look at the patterns, look at the frequency, and see if there's some way that we can work within what's happening in their world. So we need to try a constant routine, making sure their needs are met, reassuring them, place stop signs where you don't want them to go. There's always, always, always something that we're going to have to do to try to work with these individuals. But again, pay attention to the alarm. And this is everybody's responsibility. This is just not the caregiver that's taking care of them at the time. This is from the home housekeeping staff to the administrative staff. Everybody needs to be taking responsibility and working with this individual. One last thing before I close here is a warning about the antipsychotics. We have that brain that's deteriorating, and what do antipsychotics do? They further sedate that brain. So there's several things that will happen when we give these to these individuals. It's going to increase that fall risk. It's going to increase the aspiration risk. And, sometimes we wind up with the neuroleptic malignant syndrome, which thankfully is treatable. It is. But it can last about 7 to 10 days, which is not a very pleasant thing because it's a high temp, 102 to 104. They have muscle stiffness, increased heart rate, and maybe even hyperventilation that goes along with this, but definitely it's going to be increased and anxiety that goes along with that as well. So those are the primary things that we're looking at as far as looking at the behaviors or expressions of need. And before I close, I would like to thank all of you who are taking care of individuals, and not necessarily just those with dementias, but all of our people, because COVID has made it a very challenging time. And we need to remember why we do what we do. Rabindranath, boy, it's easy to say, Tagore, actually wrote something that I thought was very impressive to me. He said, "I slept and dreamt that life was joy. I awoke and saw that life was service. I acted, and behold, service was joy." Why did we get into taking care of individuals in the first place? Because of that compassion. Remember that zeal that you had starting out. And while it can be very difficult sometimes taking care of somebody who has a dementia, it can be very challenging. Remember, it's challenging for them too. So thank you so much for allowing me to come and talk to you today. I really do appreciate it. If anybody has any questions, I'd be more than happy to answer them.
Andy, there was a question earlier back. It was, could you talk more about how to handle bad hallucinations? Do you have any suggestions?
Well, when the hallucination is there, what do you mean by a bad hallucination? Maybe somebody coming in trying to get them or something like that. You have to remember, first of all, be calm. Don't tell them that they're not experiencing what they are, because they are. It is going to be situational. You're going to have to look at each one individual. There's no set plan for it. And that's what makes it difficult to really answer that question deeply. But if somebody is maybe peeking into their room, or here's a big one, and we see this happen, is going into the bathroom to get their shower, and they don't want to get undressed because that person is looking at them. It might be simple as covering the mirror. That's going to make them feel like there's not a peeping Tom in there. But if it is something that is really, really frightening to them, make sure that you are providing the best possible calm care and get them away from the environment that they're currently in. And that may very well ease the situation. But it is situational. It really is.
Any other questions for Andy? I just want to remind everybody that you will get your certificate, the PowerPoint, and the evaluation in your email probably in about an hour. There's a question that says, what if the person is a wanderer? The spouse has tried GPS, a watch, and both items hold on, it just disappeared.
Come up missing.
And both items come up missing. Any suggestions?
Yeah, we see that happen a lot. GPS tracking shoes, we have watches, we have all kinds of stuff. One of the things, if they're at home, one of the things that I would strongly encourage is that the Alzheimer's Association has the ability to provide, you have to buy it, but it's a little bracelet, and that bracelet is Project Safe Return. And that bracelet has a number on it, and you can actually register that number with the police department and what have you, so that if they wander away and they have their bracelet on, somebody finds them, they can actually contact the police department, or if fire department or whomever you have that registered with, and they can find a way to get them home to you safely. But
Thank
the
you.
GPS is expensive.
Let's see. I don't see any other, I see a suggestion for bad hallucinations, but I don't see any other questions. I do want to take the time once again to thank Bright Star Care of Ann Arbor Brighton and Balfour Senior Living and Arbor Hospice for hosting this. Without them, we couldn't bring these type of presentations to you. Any other questions before we close down the meeting? Lots of good comments on your presentation, Andy, once again. So thank you.
Thank you. And I appreciate everybody. You guys are just amazing out there. Thank you for everything that you do.
Another thing, I am looking for new topics for 2021. If you guys have any suggestions of things that might make you a better care provider, you could put them in the chat and I can look up some qualified speakers on those topics, but I want to bring things that are relevant to you and things that you need.
I see that Barbara G put on there how she comforts her husband. And that's wonderful. You know, she said that what she does when he has bad hallucinations, that she says, "I'm so sorry, honey, I don't see what you see," and then touching him. And it was important to be in it with him. That is extraordinary. That's wonderful.
All right. Well, it looks like we are good to go today. Everybody go forward in your afternoon with a positive attitude, and we will see everybody next time. Thank you so much.
Thank you. Bye-bye.
Thank you. Bye-bye.